Okay, we're going to go through all the different types of cancer medications. And I want you to remember, not all cancer medicines are chemotherapy. Don't say chemo unless you mean chemo. Just say cancer medicine. So here's all the different types. Now let's go through from the oldest to the newest. So here is a normal cell. You've got the green DNA there is good. If the DNA goes bad, that becomes a cancer cell, right? So the oldest cancer treatments are actually hormone therapies. It was known for hundreds of years, thousands of years, the Greeks took out a woman's ovaries and found that breast cancer got better. So hormone treatments are some of the most common treatments, especially obviously for breast cancer and prostate cancer. Many women, many men are on oral medications to block estrogen or testosterone. That's not chemotherapy, right? But those work inside the DNA and affect cell expressions of different proteins that drive the cells. Now, the next oldest are the cytotoxic therapies. We still use cytotoxic chemotherapy in tons of different settings, especially the curative setting. Most curative regimens involve cytotoxic chemotherapy. Those affect dividing cells, right? So they have two general mechanisms, those that affect DNA and those that affect microtubules. In general, that's the way cytotoxic works. Cytotoxic therapies works. Those are chemotherapy. They have those side effects that people think about, like nausea, hair loss. Not all of them cause nausea, not all cause hair loss. In general, they can all cause low blood counts. And then neuropathy. Those are the big cytotoxic chemotherapy complications. So then it was known in the 80s and 90s, these specific proteins that affected the cell cycle, and they figured out how to target them. The oldest targets that are still probably the most important targets are HER2 and CD20. The first targeted therapy, monoclonal antibody that came out in the late 90s was trastuzumab. That drug is still used every day by millions of women around the world. It's a monoclonal antibody. So we have all these different monoclonal antibodies that are generated to stick on the outside of cells. HER2 is a tyrosine kinase inhibitor, and the tyrosine kinase inhibitors are one of the most important classes of therapy. In fact, almost all the targeted therapies affect these tyrosine kinases. Some of them, like HER2 or EGFR, are cell surface receptor tyrosine kinases, and you can block those with an antibody. There's other cell surface markers like CD20 in lymphoma that doesn't actually do anything, but you can target that with an antibody too. So that drug is called rituximab. Now, there are other tyrosine kinases that sit inside the cell. Now, if you're going to get these, you got to get it with the oral therapy. The first oral targeted therapy, also late 90s, was to block BCR-ABL, that fusion tyrosine kinase that is in CML. That drug is called imatinib or Gleevec, still used today, but now we use more commonly other generations of these. Now, there's all these different cell surface markers, receptor tyrosine kinases like EGFR is very important for lung cancer, colorectal cancer, but you should think about there's two targeted therapies, two ways to block these, either oral tyrosine kinase inhibitors work inside the cell or monoclonal antibodies. Any targeted therapy in general is going to be one of those types of drugs, either oral therapy or monoclonal antibody. Now, if you wanted to make that monoclonal antibody more effective, what you can do is stick a cytotoxic chemotherapy onto that. This is called an antibody drug conjugate. So if you take trastuzumab and you put a really powerful cytotoxic on that, you create an antibody drug conjugate. One of the most common one used these days is called trastuzumab deruxtecan, but there's lots of these classes of antibody drug conjugates you have to know about if you're an oncologist. And the side effects are going to come from that cytotoxic therapy. So it is a chemotherapy, but it's a targeted chemotherapy. It's pulled inside the cell and works inside the cell. Now, so that kind of gets you to where we were in like the late 2000s. So we had antibody drug conjugates with more and more antibody drug conjugates now. But antibody drug conjugates have been around for a long time. You'll hear people say ADCs. Now, for ages, people have known if we could just activate the immune system, then that would make a big difference. Interferon was used to turn on all the T cells, all the inflammatory cascade. That's still sometimes used, very rarely in kidney cancer and melanoma, but in general, there's better ways to activate the immune system. So how can you get this T cell to work? So there's a whole class of drugs that interfere in this pathway, the programmed death ligand pathway. So T cells have a programmed death receptor that when you're a kid in your thymus, they are learned to turn off. So you have to have a way to turn off your T cells. So these are called checkpoint inhibitors, because as the T cells move through this checkpoint process, the programmed death ligand turns them off if they're sensing self. So What cancer cells learn to do is they make this programmed death ligand, and it basically kills your T cells. So how are you going to block that pathway? Well, you can have a monoclonal antibody that sticks on PD-1 or PD-L1. So these are, again, now the most common drugs in cancer. Pembrolizumab or Keytruda, nivolumab are some of the most common ones that are used that are programmed. They're PD-1 antibodies. They're also PD-L1, but basically those are called checkpoint inhibitors. What happens if you turn on all somebody's T cells or you prevent the T cells from dying? Well, you get autoimmune disease. So the complications of modern immunotherapy are autoimmune disease. You can get so common endocrinopathies, thyroid problems. You can even get diabetes. The most common problems are diarrhea and skin rash, but you can have any really severe autoimmune condition from these. But nothing like chemotherapy. Don't say chemotherapy unless it is a cytotoxic chemotherapy. These aren't suppressing the immune system, they're activating the immune system. Okay, so those are checkpoint inhibitors. Now, what if you really wanted, instead of turning on all the T cells, you wanted that T cell to go after one specific thing? Well, what you could do, if you wanted to activate that T cell receptor, you make an antibody that is a bispecific T cell engager. That's what that BiTE drug is. It has two different, it's an antibody with two different ends. So it has the target, which here we CD20 in this picture, and then T cell receptor. CD19 is actually the B cell one that's used more often, but just for purposes of the figure, you can design a bispecific T cell engager antibody really for any surface target. Now, these are very commonly used in lymphomas and leukemias, and then more and more in solid tumors, especially so these days small cell, and then other solid tumor bispecific T cell engagers are coming out. So that pretty much gets through almost all the classes of therapy would fit into one of these. So just to kind of go over the history, right? So chemotherapy, cytotoxics, those have been around since the 40s. Hormone therapy, the oral hormone therapies have been around since the 60s. Monoclonal antibodies were developed in the 90s. In general, they have minimal toxicities, and they're usually combined with chemotherapy. The tyrosine kinase inhibitors developed in the early 2000s, late 90s, and there are just scores of tyrosine kinase inhibitors. They tend to target the VEGF pathway or specific mutations. So if you have a patient with a specific point mutation that activates something, then you want to find a targeted tyrosine kinase inhibitor for that. Then the antibody drug conjugates, those have been around since the 2010s, and they're one of the most popular areas for new drugs now. New ADCs coming out every few months with different targets. And again, the toxicity of those are the chemotherapy that's attached onto that antibody. And then the BiTE drugs, the bispecific T cell engagers. So these don't cause autoimmune toxicities. It just depends on what they're getting rid of, right? So when you turn on the T cells, people can get cytokine release syndrome where they get sick. They have almost a sepsis picture, can have CNS side effects. And then it would be immunosuppressive if you're targeting B cells, for example. The CD19 drugs are some of the most common ones. So that would get rid of all your B cells. You'd be profoundly immunosuppressed. But depending on what that target is that the T cells are going after, that's what you have to understand to know what the side effects would be.